Hello everyone, thank you so much for coming back. Let's continue our journey of the metapathology. This is the lecture number 2. After the first lecture in January, I got some feedback. Especially I was told my volume was not great. So this time I tried my best to increase my volume and hopefully you can hear me clearly. As planned, this time in February lecture, we will talk about the malignant epithelial neoplasm plus the soft tissue neoplasm, as well as the melanocytic neoplasm. It will be a very heavy topic, and I will try to speak a little bit fast. This picture has been shown in the last lecture, and it's just about our breakdown of the epithelial neoplasms. And today we will talk about the malignant counterpart. This is just a quick go through the histology of the epidermis. In the epidermis, we can subdivide them into the stratum bacilli, stratum spinosum, stratum granulosum, which is the granular layer, stratum lucidum, which only exists in the acroskin, and the stratum corneum, which the corneum should have no retained nuclei. If there is, we call them perikeratosis, which we will discuss in the next slide. And here is the normal H&E. You can see the basal layer, which spinous layer, and the granular layer. This is just a demonstration of the normal maturation. In the matured epidermis, there should be presence of granular layer. If there is loss of granular layer, means it is abnormal maturation or prematured epidermis. And this one is the acroskin. It has the presence of the stratum lucidum, and in non-acroskin there shouldn't be the stratum lucidum. Let's use this metaphor to explain how perikeratosis happens. The perikeratosis basically means the keratinocytes is moving upward, but they are moving too fast. They don't have time to lose their nuclear structure, and then they kept their nuclear structure on top of the stratum corneum. And I use this metaphor to explain. This guy, maybe he has time to take off all the clothes and jump into the sea. Instead, this guy on the right is in a rush to save someone is almost dying in the water. So he does not have time to take off the clothes. So that's the difference, retain of the nuclei. The first disorder I would like to discuss is the actinic keratosis, or in abbreviation AK. AK is a very common disorder in senior people, especially when their skin is more fiery and light colored. The area of involvement usually is the sun-exposed area, such as head and neck and the extremities. And in the warm areas, such as in Louisiana, people wear shorts a lot, so bilateral pretibial region is also a high-risk area. Let's talk about the histology. We can borrow the similar concept from the GYN pathology. You can imagine this is the squamous layer of the epidermis, and we can see some atypia in this epidermis. However, the atypia only localized in the lower portion of the epidermis, and we can see there is still a maturation. It's because you can see the granular layer still present. With the presence of the granular layer means there is atypia at the bottom, but the cell still maturing. That is assuring this is not a full thickness of atypia, then it's not a squamous cell carcinoma in situ. And another feature is even there is atypia in the lower portion, but the hair follicles, they are spared. And because of the sparing of the hair follicle, the stratum corneum on top of the hair follicle, they still mature. So you can see there are normal basket wave stratum corneum. That in the cross section, you can see we use this one as a flag sign, means it's a pole of a normal basket wave stratum corneum with perikeratosis on top of this solar elastotic dermis. Those are the characteristic features of this actinic keratosis. There are different variants of the actinic keratosis. Today I will just give you two examples, including the hypertrophic and the pigmented. This is a variant of actinic keratosis we call hyperkeratotic actinic keratosis, and HAK for short, and it is forming a cutaneous horn. The cutaneous horn is a clinical diagnosis. You can see them with associated either actinic keratosis or seborrheic keratosis or wart. So in the pathology report, we should only report what is associated with cutaneous horn, but not report the cutaneous horn itself. Here is the example of pigmented actinic keratosis. Clinically, it can resemble a lentigo maligna or melanoma in situ, and so it got biopsied. But under the microscope, we can see there is only atypia in the lower portion of the epidermis. One unique feature is the brown melanin inside of the atypical keratinocytes in the basal layer or slightly above, but there is no proliferation of melanocytic neoplasms, so we give the diagnosis of pigmented actinic keratosis. When the long-lasting actinic keratosis progressed, when the atypia involved the full thickness of the epidermis, then we have a diagnosis of squamous cell carcinoma in situ. We used a similar concept in the GYN pathology. As shown here, you can see there is atypical mitosis going up into the upper portion or upper third of the epidermis with no granular layer. With or without granular layer is a very important finding to help us to decide if this is just a bad actinic keratosis or it reached the diagnostic criteria of squamous cell carcinoma in situ. Squamous cell carcinoma in situ can derived from a long-lasting actinic keratosis. However, there are other types of squamous cell carcinoma in situ. They are de novo. Usually it is associated with some viral infection or some other genetic abnormality. In this situation, when we see there is de novo squamous cell carcinoma in situ with a very unique histology, we gave the diagnosis as a Bowen's disease, which is a term very specially used in the Dermpath world. Clinically, they can represent as erythematous plaque and with a crusted surface, and their histology is the full thickness of atypia with increased mitosis. Here is the picture. This is the histology of the Bowen's disease or squamous cell carcinoma in situ, and you can see there is full thickness of atypia with loss of granular layer, means there is no normal maturation. Also, the mitosis can go up, also reach the top of the epidermis. There are two interesting signs. One is called eyeliner sign, basically means the basal layer is retained, resemble the eyeliner. And another one is the Paget cells. The squamous cell carcinoma in situ, if they go laterally, they can have those pagetoid cells involving the periphery of the lesion. You can see those pagetoid cells. But if you look closer, you can still appreciate the presence of the bridging of the squamous cell carcinoma. This is just a quick refresh of pagetoid cells. Pagetoid cells means there are scattered buckshot-looking cells scattered in the epidermis, and the top differential diagnosis including the Paget disease, which usually in the breast extramammary Paget disease in the groin area, squamous and melanoma in situ. There are other rare examples of pagetoid cells, including the mycosis fungoides, Burkitt cells, species carcinoma, and the porocarcinoma, but you should focus on those three. And immunostains can help you out to stain those Paget or extramammary Paget. They are adenocarcinomas. They should positive for low molecular weight cytokeratin 7 and 20. For squams, they are positive for P40, CK5-6, which is a high molecular weight. Melanoma in situ is melan and SOX10. Usually I prefer the combination of P40 of SOX10 unless it's involving the breast or the groin area. Next, let's talk about the invasive squamous cell carcinoma. The invasive squamous cell carcinoma is the second most common skin cancer and the risk factor is the same as the actinic keratosis, including the UV light and HPV and chemical burn, transplant, and the genetic syndromes. Usually they present as the red papule with a very thick scales, and in terms of the anatomical location, the sun-exposed area, including the head and neck and dorsal extremities, are most vulnerable area. And histology, not only we have the full thickness atypia as the squamous cell carcinoma in situ, we also have the invasion. And here is the example of the squamous cell carcinoma, and we can see there is an invasion of the atypical squamous cells. I just want to point to one thing. We see squamous cell carcinoma everywhere in the head and neck, in the lung, but in the skin world, when you see there is a very deeply invasive squamous cell carcinoma, pay attention to the periphery. Peripheral areas. If you see there is a perineural invasion, remember to report that, because if the perineural invasion or the involved neuron is more than 0.1 millimeter in diameter, that means it has a higher risk and they need to give a more aggressive treatment. Just pay attention to that. In the skin, we also have well-differentiated, moderately differentiated, and poorly differentiated squam. And as in other part of the body, when we say poorly differentiated, means we, from the histology, we cannot tell the origin of the cell. And as the picture showing here, the cells exhibit significant cytological atypia, and we cannot tell if they are squamous cells or if they are melanocytes or some other of the sarcomas. So we can use the immunohistochemical study to help us out, including the most, I think most sensitive immunostains, including the higher molecular weight cytokeratin or the CK56, and another one is the P63. Usually when you stain those two, at least you can see a few cells being highlighted. If they are not being highlighted, you just expand your IHC panel, including the pancytokeratin, the CAM 5.2, which is a low molecular weight, and also add the P40, etc. When I mentioned the squamous cell carcinoma is the number 2 most common cancers, of course you know the most common cancer in a human being is the basal cell carcinoma, and it has almost 3.6 million basal cell carcinoma in the United States each year. So how common it is I would say 10 times more common in the breast carcinoma, which is the most common non-skin cancer in female, and that demonstrates how common the basal and the squamous are. And the basal cell carcinoma, is the risk factor is also due to the UV exposure. So then you understand it is more common in the light skin colored people. And here is the histology. We have seen the basal cell carcinoma very often, and the general histology, including the cells being very basaloid, means high NC ratio. However, there are a few very important features, including the retraction artifact, means there is a separation between the tumor and the surrounding stroma. Also, the basaloid cells at the periphery of the neoplasm showed more palisading, means they are like picket fence. Also, you can see in the retraction artifact or in the stroma, there are some mucin inside. Also, if you had a hard time to tell this basal cell carcinoma from other basaloid neoplasms, such as basaloid actinic keratosis or basaloid squams, you can use a stain. If you read books, usually they recommend 2 stains, including the BER-EP4 and the BCL2. From our experience, the most commonly used one is the BER-EP4, but most of the time you can tell the basal cell carcinoma from the morphology, and you don't need to stain them. This is the example of superficial basal cell carcinoma. You can see those nests, they are all connected to the epidermis without a nodular component. People believe this could be the initial step of the carcinoma transformation. And this is the type of nodular basal cell carcinoma. This is the most common one. I believe you have seen this a lot. Next subtype is we call pigmented basal cell carcinoma, and this one is more commonly in the darkly pigmented races, and there can be many melanin and melanocytes within the tumor. If you stain with a melan A stain, you can see the melanocytes are everywhere, but they are not forming nodules. That's a big difference between the melanocytic neoplasm. So why we separate them apart is because clinically it can resemble a big nodule and mimicking melanoma. Next variant of basal cell carcinoma is February epithelioma of Pincus or Pincus tumor. The common location is on the lower back, presented as pedunculated or soft lesion. And histologically, you can see this very thin anastomosing strands. They are forming those networks, and the stroma, they are myxoid and pink. Even though it does not have the typical basal cell carcinoma morphology, but most people consider this is a variant of basal cell carcinoma. It's not very common, but the board test like this diagnosis. And this is a very aggressive form of basal cell carcinoma. In general, the basal cell carcinoma is not aggressive, but the sclerosing type is one of them. You can see the stroma looks different. They are very pink and sclerotic, and because of the sclerotic stroma, the basal cell carcinoma, they are compressed into this either passively tie or ungulated shape, and clinically they look like a scar. So if you have this type of morphology, you should think other passively tie type tumor, and I will include a slide in the next section to talk about the differential diagnosis. If you have anything in doubt, you can look closer if there is perineural invasion that will confirm the diagnosis, and it is staining positive for BREP4 and BCL2. Okay, we finished the basal cell carcinoma part. Let's move on to one of the common adnexal carcinoma, which is the sebaceous carcinoma. The sebaceous carcinoma is most commonly located in the eyelid. So whenever you receive a skin tumor around the eyelid, you should put the sebaceous carcinoma in your differential diagnosis even without looking at the slides. It is associated with Muratory syndrome. I hope you still remember from our previous lecture. And when you see the clinician, maybe they request the 4 immunostains to tell if the patient have the Muratory. It has a very high metastatic potential, so don't miss the diagnosis as basal cell carcinoma, because it has the basaloid locations, basaloid parts, and some necrotic, very pink parts. So it's a blue and pink tumor, and the growth pattern can be very infiltrative, and as we mentioned in the pagetoid section, they can have pagetoid migration into the epidermis. Pay attention to this part. You should see atypical mitosis to make the diagnosis of carcinoma, because the sebaceous neoplasms, they can have many mitosis, does not mean it is a carcinoma. That rule also applies to other adnexal neoplasms such as pilomatricomas. So sebaceous carcinoma. And here is some more pictures showing the sebaceous differentiation, the blue cells, sebaceous cells, and also you can see the pagetoid distribution of the sebaceous carcinoma inside of the epidermis. Next disorder is an aggressive form of the adnexal tumor, which people believe this property is from the sweat duct, which is the name is microcystic adnexal carcinoma, and it has a very common location, which is near the nose or upper lip, and presents as indurated plaque, and it can be very locally aggressive, so do not miss the diagnosis. Let's talk about the histology. This is the example of microcystic adnexal carcinoma, or MAC for short. And if, to be fair, if they want you to make the diagnosis of MAC, they should not give you a superficial punch or shave biopsy. They should give you an excisional biopsy to include very deep tissue, because To make the diagnosis of MAC, you need to see the entire lesion. You can see it has a very deep infiltration, and with in the deep portion you can see lymphoid aggregate. This is a unique feature of this diagnosis. And when you zoom in, you should see bilineage differentiation, including the follicular and the sweat duct. When we talk about follicular, we are talking about the cystic formation, and when we talk about sweat duct, you can see those ductal morphology. So those are the features of MAC. Again, deep tumor, bilineage differentiation, very pink stroma with perineural invasion and lymphoid nodules. One interesting feature is the MAC, the cytology is very, very bland. So that is a little misleading, but remember, this is a very aggressive tumor. I will have a slide to have the differential diagnosis later. So let's talk about the pastry tie or tadpole tumor. I think for board purposes, this probably is a little bit beyond the regular AP and CP requirement, but I understand some of the board prep videos, they included this. Probably it's a next level, I don't know, but I will just put it here and try to use my own language to make you understand this better. The syringoma, it has a unique location. It usually happens in the lower eyelid of Asian female, and it's usually bilateral and multiple. And since it's syringoma, they composed of many ducts without a follicular differentiation. The DTE or desmoplastic trichoepithelioma, from the name you can tell it is a follicular differentiated tumor, and you can see many horn cysts means there is a follicular differentiation, and it has a unique demographic pattern, which is young female and on the cheek with a centrodel. The infiltrating basal cell carcinoma and the MAC, both of them are carcinomas, and as we know that carcinoma usually has the mitosis, apoptotic cells, which do not have the features in the syringoma or DTE. And the stroma has mucin, which implies which more supportive of infiltrating basal cell carcinoma. However, in the MAC, even it has a carcinoma in the name, but it look very, very bland. So as we mentioned in the MAC slide, if they want you to make the diagnosis of MAC, it should not be a superficial biopsy. It should be a very deep excisional biopsy, so you can see it has an infiltrating pattern from top to bottom. And clinically, it usually happens in the cheek or lip of a middle-aged patient. And key feature, bilineage is the keywords with a lymphoid and perineural invasion. To help you understand it for exam purposes, so if you see a young patient with centrodel and calcification, think this one, desmoplastic trichoep. If you have eyelid and multiple, think syringoma. If you have deep bilineage, think MAC. If you have atypia plus mucin, think basal cell carcinoma. So this is the section I want you to remember, the lower part. Next is the Merkel cell carcinoma. The Merkel cell, they are the mechanoreceptors in the skin, and they are neuroendocrine cells, so they are staining for neurofilament, synaptophysin, chromogranin, and NSE. Interestingly, the cells are also positive for CK20, which with a paranuclear dot pattern. And when the Merkel cell become a carcinoma, they also retain this staining pattern. Locally, it is an aggressive tumor and usually happens in the elderly head and neck sun exposed area. And one virus is associated with this Merkel cell carcinoma, which is the Merkel cell polyoma virus that is highly testable. You should remember that. And here is the histology of Merkel cell carcinoma. If you only look at the Merkel cell carcinoma from low magnification, you may misdiagnose this one as a basal cell carcinoma. However, as all the slides, we need to look at least at one level with a high magnification. You look at the high magnification, you realize it's not a basal cell carcinoma because all the criteria we mentioned, including the peripheral pallidolin retraction artifact and the mucin, they are not exist here in the Merkel cell carcinoma. And then you pay attention to the cytology, you can see they have the salt and pepper chromatin without prominent without nucleoli at all. Then you should think about this neuroendocrine tumor in the skin. And one important differential diagnosis is the metastatic small cell carcinoma from the lung. So that's why when we stain, we need to stain CK20, which we expect to see paranuclear dot-like pattern, see synaptophysin chromogranin positivity, while negative for TTF1 and CK7. There is one thing they like to test is the P63 positivity, usually indicates a worse prognosis that is testable. Next, I will talk about the hemangiomas very quickly. So this we call cherry hemangioma, which is very common in senior. If you look at yourself, you may see one or two on your body, extremities, and histologically only has ectatic vascular channels. And the next one is we call the AV hemangioma, arteriovenous hemangioma. Some people believe it's just a malformation, and you can see on the lower magnification there are larger thick wall blood vessels with a thin wall blood vessel, so AV hemangioma. And the third one is we call infantile hemangioma, usually present at birth, then it rapidly grows. Histologically, you can see those solidly packed endothelial cells. And here is the morphology. Those cells, they are very tightly packed. And one testable point is the GLUT1 positivity in the infantile hemangioma. Why is that important? Because if the GLUT1 is negative, then it's another disease we call congenital hemangioma. It's different. So I think at this moment, you just remember this is more than enough. 3 hemangiomas. To the hemangioma, let's talk about the glomus tumor. And the glomus tumor derived from the glomus bodies, which is a modified smooth muscle tumor, smooth muscle cells. And the common location is the acral area, such as subungual or the palm. And it's one of the painful tumor. I hope you still remember the mnemonic land and egg tumor. And the cells, there are rows of very round darkening nuclei with a little cytoplasm. And some people describe this one a string of black pearls. And since it is derived from the smooth muscle cells, it is positive for SMA, but they are not the mature muscle cells, so they should not be positive for Desmond. And that is the glomus tumor. Pyogenic granuloma is quite common, and from the histology you can see it composed of those lobular-shaped capillary proliferation of endothelial cells. There is no significant cytological atypia, and most of the RBCs are inside of this vessel. So the pyogenic granuloma is a misnomer. It's neither a pyogenic nor is a granuloma. So the preferred term is lobular capillary hemangioma. However, our dermatologists, they don't like this term. It is associated with trauma or pregnancy or OCP use, and the histology is relatively bland. Then that will lead us to a different disorder, is Kaposi sarcoma. The Kaposi sarcoma is associated with HHV number 8, and there are many variants. I believe the board will like to test this. There should be 4 different variants, including the classic Kaposi, which happens in the Mediterranean, in the Ashkenazi Jewish population, elderly males in the extremity. In the African endemic, usually happens in the young African males. And if the patient had lots of immunosuppressors, there can be genetically immunocompromised type of Kaposi sarcoma. And lastly is the AIDS-associated Kaposi sarcoma. In terms of the histology, even we have the three different stages, including the patch stage, plaque stage, and the tumor stage. But the basic histological changes are similar, which is the spindle cell proliferation with extravasated red blood cells, and because of the RBC outside of the blood vessel, when they died, there can be deposition of the hemosiderin, and as the picture implies. Indicated here, you can see the extravasated RBCs in between the spindle cell and the hemosiderin. The hemosiderin, when you take the picture or using the microscope, when you flip the condenser down, you can see those hemosiderin, they are refractile. In contrast to the melanin pigment, they are not. So that's the way to tell them apart. If you're not sure, you can do Perth iron stain or Persian blue stain to highlight them. And HHV8 is 100% sensitive and specific. So that is the stain to go. Next tumor is the dermatofibroma. It's a dermal tumor, well sharp demarcated on the skin, usually happen on the extremities. Histologically, it is not well demarcated, but they are poorly demarcated in the dermis, and sometimes it can involve a superficial portion of the fatty tissue. And if we go to the high power, they are composed of spindle cells. The spindle cells at the periphery, they have a unique pattern. They are wrapping those collagen bundles. We call that collagen trapping. Another interesting feature is that at the dermal-epidermal junction, there is a follicular induction. If you don't know that term, just remember it resembles superficial basal cell carcinoma. So when you see this, don't call this basal cell carcinoma. Pay attention to the dermis. This is a feature of DF, and it is positive for factor 13A, while negative for CD34. So if we have a reverse staining pattern, you should think DFSP, which will be included in the next slide. So this is the DFSP, and in contrast to a single lesion, it usually presents as a multiple poorly demarcated tumor. Some areas look more indented, some areas has a polypoid shape, and the common location is middle-aged guy's back or shoulder area, and it is a locally aggressive tumor. And the tumor self, if you only look at the cytology, it is not a very ugly tumor, and it's because of the translocation. And in general, as we know or learn from the soft tissue pathology, all the translocation associated sarcomas, usually their morphology is not as bad. And the staining pattern we know is CD34 positive and factor 13A negative. One thing to tell it apart, just from the histology, we do not usually need to do the immunostain if we have a classic morphology, which is the storiform pattern. You can see the storiform pattern of the spindle cells and the infiltrating into the fat, forming this honeycomb pattern. If you have those features, you don't need the stain, you just call DFSP. But for your test purposes, you remember the CD34 and the factor 13A. In real life, we only do CD34. Solar lentigo is a very common diagnosis, and usually happens on the sun-exposed area, such as the face, dorsal of hands, etc. Can also happen after the PUVA therapy, and in the old days people call this liver spots. And we got the biopsy of this solar lentigo because they clinically can mimic lentigo maligna, which is melanoma in situ. Histologically, you can see those hyperpigmented basal layer with elongated club-shaped reedy ridges. And if you don't remember this one, just try to remember the dirty puppy feet, or dirty socks, or dirty shoes, whatever, dirty boots, whatever you like. But in general, there should be no nest of melanocytes. If there are nests of melanocytes, then the diagnosis won't be solar lentigo. Instead, they will be melanocytic nevus. Also, there should be solar elastosis in the background. Let's move on to the melanocytic nevus. The preferred term is melanocytic nevus, not just nevus. Why is that? Because nevus, from this terminology, it just means hamartoma and congenital. So that's why we have like Becker's nevus or epidermal nevus. They are not necessarily they are melanocytic. If you are implying the nevus that is derived from melanocytes, we should use the term melanocytic nevus. And here is the demonstration of the melanocytic nevus. The left one indicates the melanocytes. They are forming nests. Nest of melanocytes is a feature to tell them apart from the lenticle. Remember, the lenticle, they do not have nest. Melanocytic nevus, they have nest. And if the nest only exists in the dermal-epidermal junction or only in the epidermis, we call this one a junctional nevus, which usually presents as a dark brown or black macule. And if the nevus, they start to going down, they have proliferation not only at the junction, but they going down into the dermis. But both components exist. Usually it is a brown, slightly elevated dome-shaped papule. Then we call compound nevus, when we have both components. And then the next step is the junctional component completely go away. We only have the dermal component. Then we call this one intradermal nevus. Then it usually presents as skin-colored pink or light brown, soft dome-shaped papule, even forming a polypoid lesion. So this is the dermal nevus. No matter which type, junctional, compound, or intradermal nevus, they are completely benign. They are biopsied because sometimes they are irritated and clinically cause some irritation, so they are biopsied, but they are benign. Next melanocytic nevus is called Spitz nevus. This was named after Dr. Sophie Spitz, who is a pathologist working in 1940s. She noticed a series of cases involving young individuals with very peculiar dome-shaped skin lesion. Initially, people called them melanoma, but she realized those cases, they have a more favorable clinical and outcome. So after her conclusion, people name those tumors as Spitz nevus, and they usually present as symmetrical, sharply demarcated on the face, trunk, or extremities of young people. How we separate the age, define young or old. Usually, if you want to make a diagnosis of Spitz nevus, pay attention. They usually are less than 30 years of age. If you are trying to make diagnosis of Spitz nevus more than 40 years of age, pay attention. They may be spitzoid melanoma. That is the general rule. So here is the histology of the Spitz nevus. If you only pay attention to the very high magnification picture here, you may call this one looks very atypical because of the very cherry red nucleoli. And if you look at this medium power, you may also think this could be a malignant because of the irregular distribution of nest of melanocytes with no obvious maturation and very random distribution. However, when you look at the lesion as a whole, look at the third picture. If you flip from this side and fold into the other side, they are symmetrical, and the base is still flat. Those are the features of Spitz nevus. Even though the cytology can look very ugly, but there is maturation and there is a symmetrical growth pattern. And those very pink material, they are called caminobodies, is also a feature of Spitz nevus. If you stain, they will be positive for P16 and S100A6. This one only exists in the exam, but P16 we commonly use it. So pay attention to the age always. The age and site for all the melanocytic lesions are critical. Do not make a diagnosis of a melanoma in a young kid unless you are 100% sure and show a very senior people. Dysplastic nevus. Why dysplastic nevus is important? It is a nevus which is benign, but clinically and histologically it can mimic melanoma, and sometimes we cannot tell them apart. And also, if your patient have many dysplastic nevi in the body, it usually has a higher risk to develop melanoma. So that's why we use this term dysplastic nevus. It looks is asymmetry, and diameter can be more than 6 millimeter with irregular border and different color in different location, can mimic melanoma. So dysplastic nevus. Let's talk about histology. The histology of the dysplastic nevus. You can see the cells at the derma-epidermal junction. They are very busy. They can even have some pagetoid cells. But in general, from left to right, if you fold it from left to right, it can cover itself. So basically, it still looks symmetrical. But cytologically, they can have some atypia. So that's the dysplastic nevus. And there are two important features we use to tell this dysplastic nevus from regular nevus is one, shouldering, and two, bridging. Bridging is easy to understand. It means the radius, because of the presence of melanocytes, they got fused together. We call bridging. And the shouldering means if the dermal component stops here, the epidermal component goes beyond the presence of the dermal component more than 3 radius. That is what we call shouldering. So shouldering and bridging, those are the features of dysplastic nevus. But in contrast to the melanoma, there should be no pagetoid, should be less pagetoid cells, and there should be no deep mitosis, and it still shows a pattern of maturation, but sometimes can be very challenging. That is one of the challenging area in our Dermpath and need special training. For your level, I think knowing the concept of shouldering and bridging, that's enough. Next disorder is blue nevus. Clinically, it looks like a blue nodule on the skin, and histologically, it composed of the wedge-shaped neoplasm of melanocytes. And under the higher magnification, you can see instead of the epithelioid-looking melanocytes, they look more spindle with a heavily pigmented cytoplasm. From top to bottom, they do not show more maturation. Means the top and bottom, the cytology looks the same, but don't be alerted. This is just the nature of blue nevus. No real maturation, but it's benign as long as you don't see deep mitosis and necrosis. If you see, you should think about the blue nevus like melanoma, but again, that's above your residency level. Next, let's talk about melanoma. And sometimes people call malignant melanoma, but malignant is unnecessary since there is no benign melanoma. And clinically, they used ABCDE criteria: asymmetry, irregular border, different colors, and diameter more than 6 millimeter, as well as evolving lesion, which means there is a new changing in size and shape or color. So histologically, it also correlates with those 5 ABCDE criteria, including the symmetrical proliferation and some pagetoid spread, different generation of the melanin. That's the in general rule of melanoma. Also, let's talk about the even though the dysplastic nevus has dysplastic, but don't be confused this dysplastic with the dysplasia in the GYN world. We do not think the dysplastic nevus is a precursor of melanoma. Just many dysplastic nevi indicates the person has a higher risk to develop melanoma. It is not uncommon to see melanoma with adjacent dysplastic nevus though. Also, let's talk about the clot level and the breath flow thickness in the next slide. Next, let's talk about the clock level and the breathless sickness. In the old days, Dr. Clark developed this scheme. Level 1, 2, 3, 4, 5 indicates the involvement of different histologic locations. But it is out of favor because nowadays people developed use the breathless sickness, which correlates better with the prognosis and the treatment. So the current AJCC TNM staging for the PT stage, we used breathless sickness, which is 1.0, 2.0, 4.0, and there are different modifiers including oscillation versus no oscillation. And you should remember this better. And the clock level, like we mentioned, is out of favor. Next, let's quickly go through the different types of melanoma, and this is just a part of the list to include the most commonly seen melanoma. And I understand to you, or especially the junior residents, the terminology in the melanoma is sometimes somewhat confusing. So let's quickly explain. The lentigo maligna actually is just a melanoma in situ, and the lentigo maligna melanoma is an invasive melanoma. It's derived from the in situ lentigo maligna, and if there is invasion, we call lentigo maligna melanoma. And we have superficial spreading. The superficial spreading means the invasive part is superficial spreading, so that is invasive. Nodular is invasive. Acrolentigenous melanoma is invasive melanoma, but if you want to say the acrolentigenous melanoma is only in situ, you use the term acrolentigenous melanoma in situ. And the last two is the desmoplastic and spindle cell melanoma. Let's go through each individually. So this is the general histology of melanoma, and you can see the melanocytes. They have a proliferation along the dermal-epidermal junction with many random nests of melanocytes here and there with pagetoid extension, upward migration into the epidermis. Also, there are nests of atypical melanocytes in the dermis as well. Also, you can see there are lymphocytes attacking those melanocytes. So some people describe those lymphocytes as smart bombs. They are trying to target those and malignant melanocytes, try to kill them. So that is the very typical picture of a melanoma. Let's talk about the lentigo maligna. Lentigo maligna is actually a melanoma in situ, but it has a unique feature, which is the lentigo maligna usually happens in the skin that is a sun-exposed area, and you need to have the evidence of sun damage in order to make the diagnosis. Why we separate the sun damage versus non-sun damage is because the molecular pathway is different. That is above your level, but that's general rule. We use different subtype to indicate what could be the mechanism behind the scene. The lentigo maligna can be very subtle, clinically and histologically. So when dermatopathologists misdiagnose something, usually is when they misdiagnose of a melanoma, and the lentigo maligna is one of them. And you usually need to stain to evaluate this lentigo maligna from melanocytic hyperplasia. Let's give you a picture. Next is the histology of the lentigo maligna. And if you remember the histology, the melanocytes, they should separate apart at the dermal epidermal junction. But from this picture, you can see in the background of severely sun-damaged skin, the epidermis becomes very busy. And you can see there are random nests of melanocytes with tons of pagetoid extension. As depicted here, you can see those abnormal looking melanocytes with many pagetoid cells. So those are the features of lentigo maligna. And when there is invasion in the background of lentigo maligna, such as here, you can see there is a nest inside of the dermis. That in the background of lentigo maligna, we use the diagnosis as lentigo maligna melanoma. Basically means lentigo maligna with dermal invasion. Next is the superficial spreading melanoma, which is the most common type. It happens in the non-sun exposed skin, and there should be no solar elastosis. Other than that, the histology should look similar. And here is the picture showing the superficial spreading. You can see there is abnormal looking melanocytes with a confluent growth pattern at the dermal epidermal junction with hyperchromatic lack of maturation melanocytes in the dermis. This is the superficial spreading melanoma, so in the background you should not see severe sun damage. The nodular melanoma basically means the intraepidermal component, they have a radial growth instead of horizontal growth. And by definition, the intraepidermal component should no more than 3 radial ridges beyond the nodular invasion. Means the entire lesion is going downward instead of horizontally growth. Let me show you the picture. And here is the picture showing the nodular melanoma. You can see it has a nodular growth without a horizontal growth. Next disorder is the acrolentiginous melanoma, and you may see it has with in situ, means it is only in situ melanoma. If it does not have the in situ component, means it is invasive. So pay attention to the details. It happens in the foot or palm of dark-skinned people, usually Asians or blacks. And also, when Asians and blacks, when those people have melanoma, the acrolentiginous melanoma is more common than in the but else part of the body. And clinically, it can mimic a benign acronevus, but histologically, there should be cytological atypia and pegytoid cells. Here is the histology of acrolentiginous melanoma, and you can see those are the separation. The separation is because there is confluent growth of melanocytes. The melanocytes, they don't like the keratinocytes. They have the desmosome. Since they don't have the desmosome, they cannot hold the epidermis to the dermis. Then there is a separation. It's not a real separation, it's just a histological separation. So that's why you don't see bullous on the melanoma usually. But here, not only we have in situ melanoma in the acral skin, but also we have those invasion part. So this is acrolentiginous melanoma. Again, if we cover this area without invasion, we just call acrolentiginous melanoma in situ. Let's quickly summary the superficial spreading melanoma. You can see there is a superficial spreading. Nodular melanoma means the entire thing is going downwards. Lentigo maligna melanoma is usually in the sun-exposed area, showing chronic solar damage. Acromelanoma, so this is the nail. This is the nodular acromelanoma, and you can see the melanocytes having very atypical morphology. There are two types of melanoma. Their staining pattern is different, and they are very testable in your board or RISE exam. One of them is the spindle cell melanoma. The spindle cell melanoma, the entire lesion looks more spindle, which can resemble other spindle cell neoplasm, which is the SLAM is the mnemonic. And the stain of choice is the SOX10. We all know that the melanomas, they can stain with S100, but S100 is not the right answer here, because S100 can stain lots of things, and SOX10 is more is sensitive and specific, so that is the one to go. At this time, the melan A stain, which usually is very useful in different other types of melanoma, is not positive in this type of melanoma. Spindle cell melanoma only stain for SOX10. So here is the histology. You can see in the dermis there is a proliferation of spindle cell neoplasm. Also, you can see there is lymphoid aggregate. Pay attention, in the future of your practice, if you see a senior with in the sun damaged area and lots of spindle cell with lymphocytic infiltrate, make sure it's not a melanoma. And again, melan A won't work here, only the SOX10 will work. S100 is working, but S100 is not very specific, so SOX10 is the choice. Okay, let's give a very quick summary of SLAM tumor, which is the dermal malignant spindle cell tumor, including the squamous, leiomyosarcoma, AFX, and melanoma. In terms of the staining, squamous cell carcinoma should be positive for cytokeratin P63. Leiomyosarcoma, they are positive for SMA and Desmin. The melanoma is positive for melan A and SOX10, except for the spindle cell melanoma, only stain for SOX10, not melan A. And lastly, the AFX, atypical fibroadenoma, is a diagnosis of exclusion. When you throw all the immunostains, then everything is negative except for CD10, then you can make the diagnosis of atypical fibroadenoma. Okay, let's move on to the next topic, is the mycosis fungoides. Even though the name implies it is a fungal infection, but actually it's not. It is a T-cell lymphoma. Remember, in the skin there can be T-cell, B-cell, NK cell, and lots of other types of hematopoietic malignancy. However, in your level or for the board or RISE purposes, the only hematopoietic disorder in the skin you should remember is the mycosis fungoides. It is characterized by the epidermal trophism, means there are some weird atypical lymphocytes. They are going into the epidermis. Usually in the inflammatory skin disorder, there can be epidermal lymphocytes. However, in that situation, you should see some reason. Either there is a spongiosis or there are some dyskeratosis, and the lymphocytes are targeting those pathology. In this situation of mycosis fungoides, there is no particular reason, but the lymphocytes are going into the epidermis. This is the term we use to describe this feature called epidermal trophism, and you can see the lymphocytes are tagging this dermo-epidermal junction, as well as inside of the epidermis, forming some microabscesses of lymphocytes. So those are very characteristic of mycosis fungoides. And a mnemonic to remember is too much for too little. Too much is too much lymphocytes. For too little means there is just a little spongiosis and dyskeratosis. In reality, the patch stage mycosis fungoides sometimes is difficult to make, but I guess in your exam they should give you either tumor stage or plaque stage, means there are many atypical cells inside of the dermis as well as in the epidermis. And if you see that, just go with the T-cell lymphoma, mycosis fungoides. And the typical immunophenotype is CD3 positive and CD4 positive, CD8 negative. Let's talk about the stain in the next slide. Just like all other hematopoietic disorders, the lymphomas, they can do whatever they want. But in general, in your test purposes, this is the most common immunophenotype, which is the CD3 positive. You can see it's a highly very dense positive CD3, and the CD4 is positive, and the CD8 is very low. So the normal ratio CD4 to 8 in the skin should be 2 to 3 to 1, but in our example is much more 4 than 8, so this is abnormal. And as a general T cell marker, CD5 and CD7 should be positive in T cells, but here you can see there is a loss of CD5 and CD7. Those are abnormal immunophenotype of lymphocytes. So this is a very classical example. I think in the exam they should give you something like this. But CD5 is not as commonly lost as CD7. So remember, this pattern will be very helpful in making the diagnosis. Let's talk about the metastases. The metastases, most common one is the breast cancer in ladies and lung cancer in guys, renal cell carcinoma, colon cancer, thyroid, squamous cell carcinoma from other location. I think as a general past trained resident, you know this very well. But I just want to point out one thing is that the breast carcinoma, when they have metastases in the skin, if you only stain with CK7 and GATA3 and ER, they can be positive, but it won't be very helpful because the skin sweat duct tumors, they can stain positive for those three as well. So in general, the most common stain can help you differentiate breast carcinoma from skin adnexal tumor is the P63. The P63 usually is positive in skin adnexal but negative in breast cancer, unless you know if this is medullary features, they can have some P63 positivity, but that is some another topic then. So in general, use P63 to tell them apart. And one more thing I would like to point out is when you see the breast biopsy contains the metastases in the skin, it does not mean inflammatory carcinoma. The inflammatory carcinoma, that diagnosis or stage 4 breast cancer, that requires the presence of clinical finding of erythema and edema involving at least 1/3 or more of the breast. So only seeing metastases in the skin, either in the dermis or in the lymphovascular spaces, does not mean it is an inflammatory carcinoma. So that is one thing, last thing I would like to point out. That's a lot of information. I hope it will be helpful. And again, if you have any questions or any feedback, it's always welcome. You can email me or send me text message, and we can include that in the next lecture. And again, thank you so much for your attention. I hope you all the best, and see you next month.